And good evening, everyone. It's Dr. Bill Tullo, Medical Director of Oculus, and thank you for joining our series of webinars. If you have questions tonight during the webinar, please enter them into the chat, and we'll do our best to put some time aside at the end and answer all your questions. Tonight, I'm really excited to bring you an all-star cast. We have a really special presentation tonight on how to utilize your Oculus Pentacam for more than keratoconus screening. And our three presenters tonight, I'll start off with Dr. Cheryl Chapman. She's a graduate of the University of Houston College of Optometry and currently practices in Gretna, Nebraska. She's currently serving as adjunct assistant professor at the University of the Incarnate Word Rosenberg School of Optometry. Dr. Chapman has established a full-scope myopia management clinic and collaborates with other doctors in the integration of practice protocols. She also lectures extensively to promote awareness and understanding of myopia management. Our second doc tonight is Dr. Katalina Yandell, completed her Bachelor of Science in Biology at Northern Arizona University before pursuing a doctorate in optometry at Western University of Health Sciences in Southern California. Dr. Kat has been recognized for her impressive contributions to political activism, leadership within her field, and unwavering dedication to private practice optometry. She currently holds the esteemed position of Chief Operations Officer at Optical Illusions and is the past president of Board of Trustees of the Santa Clara County Optometric Society. And last but not least is Dr. Trevor Fosso, graduate magna cum laude from Bethel University and went on to graduate from Michigan College of Optometry. He then completed a residency program at the Illinois College of Optometry in Madison, Wisconsin, focusing on anterior segment disease and contact lens management. Dr. Fosso currently serves as Director of Contact Lenses in Pinecone Vision Center and is an active member of the American Optometric Association and the Minnesota Optometric Association, as well as a fellow in the American Academy of Optometry. Without further ado, Dr. Chapman, take it away.
Thank you. I'm very excited to be here tonight. So let me see if I can advance my slides. All right, so I'm going to kind of lead us off talking about what I do most commonly with my Pentacam. When I first got my Pentacam, I found it to be a little bit overwhelming, honestly, because there are just so many things you can do with it. There's so much data. And so you can really spend just hours and hours and hours sort of reading through the booklet and learning about your Pentacam and how to interpret that data. So hopefully we have a lot of variety with myself and the two other speakers tonight. So hopefully you all will learn a little bit more about your Pentacams and how to utilize them more fully. Basically what I'm gonna walk through is how I like to analyze my different topographical maps for Ortho-K when I'm trying to figure out how to fit a particular Ortho-K patient. And also how to use the two map comparison feature when you are looking at those cases after they have started their Ortho-K. So basically, this is your 4 maps refractive. I think that a lot of people with Pentacam probably use this feature fairly regularly. And it gives you, it's really nice to pull this one up because it gives you a very quick view of a variety of features. Are you able to see my mouse when I move my mouse on here, Bill?
Yes, we can.
Okay, perfect, thank you. All right, so really quick look at this. I can see that axial map, I can see my elevation map, I can see my posterior elevation map, and I can see my corneal topography. And so you get a really quick like overview of, oh, does this patient have, you know, a lot of SIL? Is it with the rule, against the rule? Is it limbus to limbus? Is it you know, more spherical or more in that central zone if they are astigmatic, because that will affect maybe what type of lens you choose for this patient. We know that it's harder to fit SIL that goes limbus to limbus than it is SIL that stays rather centrally. It's nice to look at the elevation map too, because you might find a patient has a lot of difference in their elevation in the vertical quadrant than perhaps in that horizontal quadrant. And if you see that, that's a real key that you need to go with a toric design lens for Ortho-K. And sometimes you even find that the superior elevation is different than the inferior elevation versus the horizontal. And so sometimes you're wanting to go more for like a quadrant specific design or a free-form design lens. And that's where your software design Ortho-K really becomes valuable, when you identify that there are a lot of elevation differences on that cornea. So super important to look at that elevation map for all fits before you design the lens. And then of course that posterior elevation map is super important to make sure that there is not keratoconus, because you don't want to be kind of artificially changing the shape of that cornea on an early cone and then not ever realize that that patient is a cone. We want to be able to drive those kids towards cross-linking if necessary. All right, so then let's kind of keep going. This is that little side toolbar. Again, I talked about how the Pentacam is so rich with data, and so I kind of wanted to highlight a few things. It's really nice to be able to know which of your scans you are using as your baseline. That's super valuable when you're doing that two-map comparison, to know which one you originally designed off of. And you can free text in this cell right here and write in what you're using that baseline for Ortho-K, or if you're doing it a baseline for an RGP or a baseline for a scleral or whatever. And then quick glance, you can see those K values, you can see how much corneal astigmatism there is, and kind of see how closely that matches up with your refractive cylinder. And then eccentricity. Eccentricity is really important because we know that a lot of the sort of off-the-shelf Ortho-K designs, if you're fitting a more basic lens design out there, having a really average eccentricity is important. An average eccentricity is around 0.5. If you have eccentricity that's really low or really high, you're probably going to do better with a software design lens than an off-the-shelf lens. And then this does a really nice quick little horizontal white to white. Remember that a lot of corneals are really more oval shaped. And so I always think of that as being a little bit of a large estimation of the visual iris diameter, because I know that if I were to measure it vertically, it would probably be a little smaller. And as long as you're aware of that and kind of make that mental note and maybe some mental computations to account for that, then you're usually in pretty good shape. So here's just a little bit closer look at that axial map. If you want to go to a single map rather than the 4 maps refractive, you can just hit one large color map, and then you can specify in this cell here which one you want, either elevation, tangential, axial, or whatnot. Here again is this patient with showing that I switched over to the elevation map. This patient in particular was pretty steep up here. It's an Asian patient with a very tight upper lid. And here is her tangential map, and you see that. And at first when I saw this, I thought maybe it was an artifact, but I had 4 maps. I did 4 maps on this patient, 4 scans on this patient to confirm that. And I also scanned her on a placido-based topography, 4 scans on that as well, and they were all consistent. And both of her eyes had this steepening on that superior cornea due to that tight upper lid. So I thought everyone on the webinar, the attendees, might appreciate just a peek into the Wave software that many of us use with our Pentacams. So it's just a newer version of Wave that came out a couple years back, and I have found it to be extremely user-friendly. I'm not diving too deep into this tonight because the talk is more about Pentacam, but I thought people might appreciate seeing what the software looks like. So let's talk just for a few minutes about the type of corneal changes that will happen with Ortho-K. So when we put that Ortho-K mold on the eye, you get that hydraulic push force on the apex of the cornea, which helps to redistribute the corneal epithelium. And then you get hydraulic pull forces out here where that reverse curve is on the lens. And that corresponds to where the majority of the fluorescein sits underneath that lens when it is on the cornea. And you can see that the corneal cell or the epithelial cells have moved into that zone or region. And then you've got your alignment curve, which is this wider dark band, and that is really, really essential for helping the lens center properly on the eye or to align properly on the eye, which is why we call it the alignment curve. And then you've got the peripheral curve out here, so a little bit of fluorescein there because that bit of the lens actually picks up off the cornea. So here we have kind of some steps on how to generate those post-treatment maps if we want to look at a two-map comparison. So you will hear these comparison maps called either subtractive maps or difference maps, depending on what lecture you're listening to. It's the same thing. Basically, you're just comparing their baseline to their post-treatment. And to do this, you go to this section right here, down on your drop down. See, there's so many different options here. And this is what a difference map or a subtractive map looks like. So we have the baseline here. We have the post-treatment map here, and you can see that apex is flattening, and this is an axial map. And one of the nice things about Pentacam is all these different data points over here. At a quick glance, I can tell how much treatment that patient has had in terms of power change on that eye at any given point. So at the apex, within, we've got those dashed lines designating the pupil, so within the pupillary zone, and that's really important for these myopia management kids because we want to know what the power of that peripheral power curve is, right? So that we can tell maybe how much peripheral myopic defocus it's causing, or maybe how much spherical aberration we expect to be going into the eye. So again, this is the axial map, very important for detecting power change. Now that's an important distinction. When we go to the tangential difference map, it looks very, very different. And what we're doing here is we're seeing that beautiful red ring. Here's your baseline, and then here's that difference map. And that red ring tells us some really important things, not power, but rather the size of the treatment zone relative to the pupillary margins. And again, with these myopia management kids, we want to be slightly inside the pupillary margins. And with an older adult or an older kid, you want to be maybe a little bit larger to reduce those spherical aberrations to give them better vision at night. They stay up later, they're driving after dark, maybe they're playing baseball under the lights. So that's an important consideration. But it doesn't just tell you the size of the treatment zone, it also tells you centration of the treatment zone. So if you want to know if your lens is riding high or riding low or decentering laterally, you really want to be looking at that tangential map. It's really interesting that, you know, the data is different on different maps just based on how those algorithms are and exactly what it's doing to the data. And so you will see the axial or the power looks a little bit different on a tangential map than an axial map. So you really don't want to use the tangential map to look at the power change. So here, again, we're looking at that peripheral red ring. We can look at that power in the ring if we want to kind of see how robust that power curve is. If you've got a really low myope, like a -1, you're not going to have a very high power in that peripheral power ring because you're not moving as much corneal tissue. So sometimes that will limit the amount of myopia control that you're getting because you're not causing as many spherical aberrations to enter the eye. So that more highly myopic eye, if you're molding somebody who's like a -3 or a -5, you'll have a much more robust power ring there, and you'll notice that it's deeper red and maybe a little bit thicker. Again, those positive spherical aberrations are really important. That will create stop signals on the retina that help slow axial growth. And then just, you know, considering the different factors with glare and halos with kids versus adult fits. And that is it for my presentation. So I think we've got Katalina, Dr. Yandell is up next.
We do, yeah. Thank you, Dr. Chapman. That was awesome.
Thank you.
Next up is Dr. Yandell. Kat, take it away.
Perfect. So thank you guys so much for having me tonight. I think all of us are specialty lens fitters, so there was definitely a place where I could have talked a lot about lenses, but I decided I wanted to kind of jump into maybe the things that you don't conventionally think about when you think about Pentacam and what you're going to use it for. I've been kind of using it on all of my patients for a couple of years now. And since I do a ton of primary care within my practices, it's interesting the insights it can give you outside of just what we're thinking about contacts, refractive surgery, and your typical anterior seg patient. So the first thing I wanted to kind of jump into was evaluating angles using your Fluke imaging. So heading over to here, I kind of just created sort of cases to give us ideas of what we're looking for. Now, we all do anterior chamber angle measurements, measuring various different ways. Maybe you're using just von Herrick grading, maybe you're using OCTs. But what's nice about using the Pentacam imaging is you can actually get a beautiful 360-degree look all the way around and actually know what the kind of whether your imaging was great or not, but whether you're how much of an angle you're going to have all the way around. So we had a high plus patient in our practice who's kind of had a little thinner than average pachymetry. She's got a little bit higher IOPs, and our doctors at the time were grading her as a VH grade 1. So when we look at, say, your degrees that you're measuring, which is what your Pentacam is going to give you, a 0 is a 0, obviously. Less than 10 degrees is a grade 1 for your von Herrick, and then your 11 to 19 is a 2, and a 20 to 34 is a grade 3. So we on a von Herrick grade her as an 1. So I wanted to go ahead and see, like, let's take a look all the way around. How small are her angles really? Now, grain of salt with these sorts of images, if you ever see these sort of parentheses out here, your camera is getting a little bit of a guesstimate. So for this patient in particular, if you kind of notice these little blue lines here, it's telling you where it's lining up along the eye. And so you can see for my superior images, I wasn't necessarily getting a great look at it. So it's kind of probably giving me an overestimate here. But we got these fantastic images across the horizontal where you're really seeing where that narrowing of the angle is. And what we actually found with this patient is they were more close to a 20.6 in that nasal zone over there. But I do love that we're able to actually see how that iris, if you have a plateau iris, you have something going on, iris Bombay, maybe having fallout of that angle, you can really see that and see that everywhere. And what that will do for me is help me guide my gonioscopy for this patient. You still got to do gonioscopy because you got to make sure that there is no PAS out there, looking for those iris processes, those kind of things. But it really helps me focus on a zone rather than like laboring over, like, am I getting a good view in a spot that was probably already perfect? So I really like using it in that way. Another way that I'm going to use this is actually helping kind of, and I'm going to say I'm going to be using this report very, not the way it was meant to be used. But I really like to show this to patients, this holiday report, as a way to help them understand how much their cornea has changed. So say you have an RK patient who is going to be the patient that I'm going to be discussing today. He is telling me when he comes for his annual exam that he's getting fluctuating vision, especially up close. He actually has fantastic vision considering he had radial keratotomy in the 80s with a LASIK touch-up in the 90s. And with that Manifest RX high plus there, or not high, but like moderate plus prescription with a little bit of astigmatism, like his VAs are fantastic. But he finds that throughout the day, that vision quality can be all over the place. So for what I did is I took Pentacam imaging at his annual exam. So you're going to see here that he's going to have an increase in elevation on the front side of his cornea, kind of down in this, lower temporal quadrant, that mid periphery there, with a 15% change in pachymetry from the central there. This screen here is just so robust, and I if I had more than 15 minutes, I would keep going. But my idea was I wanted to show just how much of a difference he was getting all over his cornea, the irregularity, and go from his CEE to our 1 week follow-up and just show him how much that changes. So you're seeing that his steepening zone over here has gotten much larger on that right eye, as well as an even bigger thinning of that pachymetry through that zone, which is where his largest radial cut was. That he was getting some very insane thinning out in that zone, which was causing a lot of issues for him throughout the day. And so this was helping me kind of just show him from here to here how much of a fluctuation he's getting, helping him recognize what's actually happening. The one thing I do want to say about this report, if you guys don't use it very often, is this is typically more for your patients who are going into cataract surgery, and it's helping you determine their candidacy for certain types of IOLs. And there's a lot of other ways to use this, but a good way to kind of determine if he's maybe a multifocal IOL candidate. And where you would look for something like that is going to be at this RMS HOA. So you're looking at your higher order aberrations. You'll see he's red right off the charts there. Anything above a 0.6 is not a good candidate for a multifocal IOL. He's sitting at a 3.2 at my 1 week follow-up for him, and a 4.1 at his comprehensive exam. So we probably already knew, not a great idea once he gets cataract surgery in the future to give him a multifocal IOL. That just confirms, like, we know this is not a great place to play him if we ever wanted to look at that option. I also liked using this report here. So this is your detailed report for the holiday. And you can actually kind of mess with your zone diameters on this one. They do a standard 4.5 on it. But this is, as we were talking about with Dr. Chapman here, it lines you up with your pupil sizes and things and kind of gives you an idea of how much of the aberrations and where his actual relative steepness and flatness of his cornea is, and the overall average corneal refraction there. So he's going to have for this visit at his comprehensive exam about a 36.6 as his overall average K. And then when we came to his 1 week follow-up, we were having a shift of almost a full diopter steeper there. So just again, recognizing how much of a shift and change even over just a week's time, even if it was the exact same time of day. For my next thing here, I wanted to just briefly touch on the super cool CSP Pro. I believe that Dr. Fosso is going to be talking about CSP as well. Our office had the pleasure of being part of the beta for the CSP Pro, and this is not the previous patient's eye, but we were able to get this beautiful 18 millimeter 360 scan on myself in less than 20 seconds per eye. So if you aren't using CSP Pro yet for your scleral fits, this is a complete game changer. Love, love, love having it in our practice. And the last thing I wanted to discuss was actually corneodensito. I use this for a lot of things, but in this particular patient, or what we've been using it now since we've had this particular patient, is actually monitoring for post-PRK haze. I do quite a bit of refractive surgery co-management with my local surgeon, and we actually had a brief period where we got 3 different patients with PRK haze, which was very strange. It did not happen very often for us. And now we use the Pentacam as a standard for all of our PRK patients and LASIK, to be honest, just to make sure that everything is going as smoothly as we'd like. So let's talk about this patient here. We have a 29-year-old Asian female presenting for a 6-month post-PRK follow-up. She came in with no complaints, super duper happy. Her prescription prior to surgery was about a -8, a little bit more on the left eye. And she had pretty thin packies. So you definitely, when you have a patient like this come in, worry that they're gonna get haze post-PRK. They kind of just seem like the perfect candidate for it. Our surgeon does use mitomycin Z for every single PRK patient. But one of the things that kind of leaded us towards thinking that she would be getting PRK haze was how much of her prescription was coming up on the auto refraction. So even though she was seeing fantastic, the auto is reading out all sorts of prescription for her that we just weren't getting in her manifest RX. So here's the pictures looking at her eyes. I'll say for sure over on this right eye, fairly subtle. Left eye, it's a little bit more going on here. We had not seen any of this going on at her 3-month follow-up before this 6-month follow-up. So we ran that Pentacam versus her 1-month post-op all the way to her 6-month post-op, and found these areas of denseness, corneal denseness, where her haze was showing up. So I'm just going to show the right eye today. And what you're going to see here as well is a huge increase in thickness in her packies. So she went from a 369 through a 390. And we're going to find as we go through this that she's actually going to kind of average out. What we ended up doing for this patient was just putting her back on steroids. And our whole goal was to just make sure that we stabilize what was happening with her cornea. So when we come to about 3 months after that, you're going to see the show 2 exam from the right eye back in February to the April exam here. That looks pretty much exactly the same, and you've gotten that reduction back down in her pachymetries, so that's good. And then we'll go ahead and see that after a year or so, she has looked to have a little bit of increase in her haze, but that thickness of her cornea has evened out. We have not seen any shifts and changes in her prescription. I have found when following something like this that the compared to isn't super helpful on corneo densito. But utilizing the corneo densito specific page, which I did not show today because I wanted to show a video, I was just worried that it wasn't going to work because tech always happens to me. But basically, if you kind of use the dragging function on your corneo densito, you can actually see how deep the haze is and where it's actually within the cornea. Can help you decide if you wanted to do any further doing like a anterior keratectomy, that kind of thing, to help this patient to achieve good vision and not get shifts and changes in the vision. As we know, with a PRK haze patient, they can have very large shifts in vision. But overall, for us, we'll continue monitoring all of our patients with this Pentacam to make sure that haze does not come up at any point. That is some of the cool stuff I do with Pentacam. I will let Dr. Fosso go from here.
Thank you, Dr. Yandell. That was fantastic. And taking us home, Dr. Fosso, it's all up to you.
Perfect. See if I can share the right screen here. All right, should be. There we go. All right, so yeah, so again, thank you for having me on. Dr. Chapman and Dr. Yandell, great information. I definitely, I'm gonna kind of go through, when I was asked to kind of talk about this, I was, thought, hey, I'm just gonna kind of go through some different cases, patients, and how I different uses of the Pentacam and how I use it in kind of a variety of different ways. And many of them, I use it very similar to like how Dr. Chapman and Dr. Yandell do, but maybe slightly different in a couple of ways. So like I said, I'll go through kind of a few different cases here to kind of give you an idea of different ways that I'm utilizing the Pentacam. And, the Pentacam, obviously I love using it for any corneal irregularity, everything like that. So we use it for monitoring, diagnosing keratoconus, but I also use it, after keratoconus, for me, I had a lot of patients referred over for especially contacts for keratoconus, and or I might have a patient that once I diagnose them with keratoconus and we start dealing with contact lenses, I'm also instantly talking to that patient about cross-linking and looking at saying, all right, let's get you in and get cross-linking done. And then I like to use my Pentacam then afterwards to monitor that cross-linking, because we know how the cornea can change, both shape, pachymetry, everything like that. And so I'll kind of show you a case here, but we've got a patient of mine, 31-year-old who has keratoconus. He wears corneal GPs and had cross-linking in his right eye just this past January. And the surgeon that he saw likes to see them usually for the first couple of weeks, and then he returns them to me after about a month. This guy showed up a couple weeks late, and so I saw him on March 13th and then May 15th after having cross-linking. And I just like to use kind of the comparison maps and looking at how the cornea is changing. So in the first map over to the, on the far left, we've got the May map, and then we've got the March map after that. And you can just see how the cornea is changing. Again, similar to like almost looking at an Ortho-K map, you can see, the cornea is changing about 4 diopters in terms of curvature after having cross-linking over that time period, over that 2 months, when he's now about 3 months out from surgery. I mean, he's been out of his contact during that whole time too, or at least most of it. And so it's kind of fun to watch that and see how that's changing and what adjustments we might need to make, especially in a patient who wears a corneal GP after cross-linking. Again, we can look at the tangential map too, just kind of see how the shape of the eye is changing a little bit more there. I also like to look at the pachymetry difference map, because we know their pachymetry is going to kind of change a little bit after cross-linking as well, and kind of track how that's going. And then similar to Dr. Yandell in terms of kind of monitoring PRK haze, after cross-linking, many of these patients are going to have hazy corneas. You know, if you see patients, some of the surgeons I work with, we get our cross-linking patients back the next day, so I see them for the one-day post-ops. And in those patients, their corneas always look really hazy. You can see this like perfect circle disc of haze from the cross-linking procedure, and then that gradually clears out. And so that's something that, you know, I found on the compared to maps, you can pull up the density map. I've actually found this because we actually don't have the corneal densitometry program on ours, but if I pull up the difference map, I kind of found a loophole, so I'm able to visualize that. So typically I wouldn't necessarily look at the difference map in this, but this is the only way I'm able to actually look at the densitometry changes on our Pentacam. But it's nice because you can see how this cornea is clearing up, you know, over a couple months after cross-linking. And we typically expect most of these people, usually around that 3 to 6 months, sometimes up to a year, it takes for that haze to clear out on them. Similar to Dr. Chapman, I'm not going to talk too much about Ortho-K, but you know, again, I use my Pentacam, but there's a little bit different change. I don't utilize the Wave software or any of those softwares yet. I'd like to, but I haven't ventured into them quite yet. So I utilize this slightly differently. But here's an example of a patient, an 11-year-old male, referred for Ortho-K, who's, you know, -325 and -375. You know, similar to Dr. Chapman, you get that baseline topography, and then I like to look at the corneal elevation map actually via the Scheimpflug image instead. It's fun to look at the global. I like looking at the global elevation, but when I'm designing a lens or when I'm uploading the data for the lens to the company that I work with, if I go to the Scheimpflug image here down at the bottom and I have it circled in red, it says sagittal height. If you click on that, it pulls up this table and it will actually show you the elevation of the cornea along the flat and steep meridian, and then you can set that to a zone diameter. And that is typically going to be for, you know, specific to each lab and their design. And so for the lab that I work with, that inner zone for their lens is at about 8 millimeters. So I can take and set that sagittal height or that zone size to 8 millimeters. And then I can look at the flat and steep meridians, look at the average height values there, and then look at the difference. And in this case, this patient has a difference of about 17 microns. Typically, we know if a patient has about 25 microns or more, that's when we usually are going to look for a toric design for our Ortho-K lenses. So this patient didn't need one to start off with. Then again, similar to Dr. Chapman, you know, looking at that difference map, we've got the single day, but then we pull up kind of those two comparisons with the axial map. Again, really showing you how much treatment you're getting. Again, for this guy's left eye, he started off as a -375. And, you know, at about a month out from starting treatment, he's got -375, 4 diopters of treatment, kind of right in the middle where you want to see it. And then again, that tangential does a little bit nicer job of showing you where that treatment is in terms of centration and everything like that. So following along with the kind of contact lens side of things, I use my Pentacam. I get a lot of scleral lens referrals. I like fitting sclerals a lot. And I use my Pentacam on almost every single one of my scleral lens patients to get this CSP, like Dr. Yandell was saying. I unfortunately do not have the CSP Pro, which is the all-in-one shot. So I'm doing it the old-fashioned way, or I'll say my technician Jaden is doing it the old-fashioned way, where she has to get 5 separate scans. So I'm a little jealous that you can get it all in 20 seconds. Thankfully, she's good enough. She can get both eyes in about 5 minutes, which when we first started with the CSP, it took the two of us about 20 minutes to get a scan on someone's eye. So it's gotten much better, but I'd love to have the Pro at some point. But a lot of the data, like I said, I use this on all of my scleral lens patients, whether it's just for figuring out what lens to start with, or actually impacting the lens design, or going as far as freeform lens design. So I have a couple of things highlighted in red boxes off to the side. Again, there's the top one says ring diameter. So depending on the size of lens that you're working with, a lens that I commonly work with is a 15.8 millimeter lens. That's the diameter of it. So I set it to that because that's the size of lens that I'm working with. And then in the bottom red box here, it shows you, the ideal, if I want to aim for 300 microns of central clearance with a 15.8mm lens, it tells me from my diagnostic set, I should grab a lens that's 4,600 microns or somewhere around there. So for me, it gives me a really good idea of, all right, this is the starting lens that I want. We have students in our practice that we have as 4th year externs. So I'll teach them how to do this, and then say like, all right, now you're going to grab this, and this is the lens that you want to grab and put on, and that should be your best starting lens. We can also take this and again look at the elevation difference along those to give us a better idea of how much elevation difference there is to help us fine tune the scleral landing zone in terms of the amount of toricity. This patient at 15.8 microns only has 74 microns of toricity, so she's fairly spherical, so not a huge difference there. We can also change this ring diameter to do like a dual sagittal depth lens in terms of adjusting that. So sometimes you'll go to the inner edge of the scleral landing zone and you can adjust things there to really fine tune the fit of the lens for a patient, getting more into like quadrant specific. Or you can also take all of this data from the Pentacam and export it to an Excel spreadsheet, and then upload that or upload it into the Wave software or some of the other programs that are out there to just do freeform scleral lens design. And I've done a few of those. They're really fun to work with. There's obviously a bit of a learning curve with it, but a really fun and pretty cool way to utilize this technology that we have. Beyond contact lens fitting, part of me, I got into contact lens stuff mostly because I just love dealing with anterior segment disease. I love disease of the cornea, and with that, I really enjoy my Pentacam. And so I really have found, using the Pentacam just gives you such a good way to view the entire cornea. So I've got a couple of cases of how just assessing the entire cornea. So this first one here is a 23-year-old Caucasian female. She was referred to me for a scleral lens fitting. She has a history of microbial keratitis, and they aren't sure if it was acanthamoeba or HSV. But you can see on the general overview, pretty irregular eye. You can even see in the Scheimpflug there how the eye just kind of pretty irregular shape in this single scan. If we look at the 4 maps refractive, again, looking at the axial map, you can see how that change in curvature, like looking at the elevation to see how that elevation changes to just give you an idea of that. The irregularity of the surface for this person, the back elevation. It's a little hard, with the scarring that she has, that can sometimes impact that scan a little bit. So I take that with a grain of salt. But then you can just see, global pachymetry. I mean, her packs are measuring, as low as 89 upward, up to around 120 in that area, and we've so she's very thin after that. So just again gives you a good idea of, hey, what do things look like for her. Looking at, again, I like looking at, even though this isn't keratoconus, for patients who have irregular corneas, I like looking at this topometric staging one, mostly for the back surface axial map, just to kind of see that irregularity there in just another way. But then in her case, something else that I like to do is I like looking at all the Scheimpflug images. The Pentacam. So we have the base level Pentacam. So it does 25 Scheimpflug images, or 25 essentially anterior segment images. And so similar to going through and looking at like an OCT of the macula, and when I have a patient who has macular edema or vitreomacular traction. I just had a patient who had that on Monday. And I'm looking at that, and we do a 21-line raster. I don't look at just the single line. I like to scroll through all 21 of them to see what's going on. And so I've found, especially for these patients who have really big ulcers or something else, that's really like a global change, not focal. I like to scroll through all the Pentacam Scheimpflug images to see how that cornea is changing, to see what the scarring looks like. It really gives you a nice kind of broad approach there. Another similar case to this is one that I just had earlier this spring, actually. And I'm sure we've all had cases like this. I've had a couple, and I always know these are going to be fun cases when my technician, Jaden, comes back to me. She's just getting started with the patient, and she hands me an article that the patient has printed off to bring me up to date on what she's coming in for. So this patient came in, she's a 24-year-old female who is suspected of having Wilson's disease. She's had a lot of blood work done. It has all been inconclusive thus far. She has not had a liver biopsy, but she'd like to avoid that. But she has many symptoms that are suggestive of Wilson's disease. And so she happened to find an article here that utilized anterior segment OCT to detect copper deposits before there's a visible Kaiser-Fleischer ring in Wilson's disease. And so she came in because we have an anterior segment OCT, but we also have our Pentacam, and I utilize that on her as well, because the Pentacam utilizes or basically creates 25 anterior segment OCT images and gives me a much better way to scan the cornea very quickly rather than trying to do all these different axes with an anterior seg OCT. It helped me scan through it much faster. And what we're looking for, so what they found in this study that this patient brought in for me, is that you can detect a hyperreflection at Desmais level. And so actually, so here's one of her scans, and you can see in this light circle, the very back, that very light white band coming out. I told her, I was like, I cannot confirm nor deny that that is copper, but you at least have a hyper reflection here that she doesn't have on the other side. And as you scroll through, as I went through all those 25 different scans on her, she had about 5 scans that had those in certain areas. And then we went back with our anterior seg OCT, scanned those areas and other areas, and again, found that hyper reflection. And then sent that off to the other doctors she was working with, and they did some more testing and then confirmed that she does have Wilson's disease. And now we're actually utilizing this as she's going through chelation treatment, you can track as that hyperreflection kind of goes away. So kind of a very rare but pretty interesting case that, like I said, was a fun way to utilize the Pentacam for her. Similar to Dr. Yandell too, another thing I like looking at, especially with the Scheimpflug image, very similar case to what she was talking about with these, high hyperopes, narrow angles. Just on the general overview, this has become, when I've got someone that I'm suspicious of, hey, what does the, this angle looks kind of narrow to me, I fall back on my Pentacam every single time. Or, if a student comes, one of my students comes in and is like, this patient's got really narrow angles, I right away pull up their Pentacam, and it shows you right on the general overview. I've got it boxed in red right there. The chamber volume, the angle, so it tells us, it's 15.6 degrees, at least in this one meridian. And, like Dr. Yandell showed, you can go around to the different meridians and see the angles there. And then it tells me the anterior chamber depth as well. And so this lady, she's a +7, she's 48. She's, tired of wearing contacts, doesn't like her glasses. So we referred her up for cataract surgery. And for me, this is just, something fun that I like to look to, and I like using it for patient education. But we can see this is what she looks like after cataract surgery. Her chamber volume has about doubled. She's at 118. The angle went from 15 up to 36. So she went from a grade 2 all the way up to a grade 4, which is great. And her anterior chamber depth went up to over than double, almost 4 rather than that 1.4. Again, this is a map that it's just kind of fun. You can do a comparison of 2 Scheimpflug images. And I use this mostly for patient education. When we talk, I've got patients, it's like, hey, the drain in your eye is not that open. This kind of puts us at risk, and we're concerned for developing glaucoma here. So, when we do cataract surgery, that'll help open, and I can show this patient, say, all right, here's where you were when you still had your cataract in place. Now we did cataract surgery, and you can see how much open that iris is on you, and it just opened way up for her. So a lot of improvement there on her. And again, just a fun patient education tool. And again, with the two, comparing 2 maps, I found with the comparing 2 maps with this little drop down right here, and I kind of wish I had taken a picture of what it looks like open. But under the compare 2 maps, there's I don't know, probably 15 to 20 different things that you can compare. And I found one of them, again, was the anterior chamber depth. Again, not something that clinically changes what I do, but it's kind of a fun thing for patients to see and really helps them hit home of like, wow, this made a big difference for me. And then kind of the final one is dealing with corneal edema. You know, the Pentacam, when it comes to measuring corneal edema, the Pentacam is one of my favorite ways to do it because it gives us this really nice global pachymetry. You know, you can see the thickness of the cornea, limbus to limbus, or at least whatever you can get scanned on the patient's eye. So this is a good example of that. And again, we can utilize then the compare to maps, which is what I do in this case, and I'll kind of show you that in a minute. But we've got a patient who's a 28-year-old male. He has a history of Fuchs, microcornea, and is aphakic in his left eye. He wears a corneal GP. His right eye also has Fuchs, microcornea. He is pseudophakic in that eye, has had a corneal transplant. Unfortunately, though, he's amblyopic, only best corrected about 2200. We've tried a contact lens on there, and it didn't really make a difference for him. So he's functionally monocular. And he came in to see me this past April, complaining that his left eye was blurry. You know, it had been, you know, it got blurrier than what it normally is, and he's normally around 20/40. And he came in, he was about 20/70, and his cornea is out, you know, with his cornea, it's always swollen. You know, he's always got some degree of swelling. Normal pachymetry for him is in like the 700s, at least the last couple of years it has been. He's been putting off a corneal transplant because, again, he only has one eye, and he's pretty concerned about doing that. But we diagnosed him. He's got this kind of little nodule with all that vascularization. It's very raised right there. There's some really deep vascularization that we were suspecting a stromal keratitis, likely HSV. So we started him on treatment, and he had significant corneal edema following that. You can see the microcystic edema just kind of everywhere in this scan down below here, and then that raised nodule with some staining around it. And for him, again, you know, every single time he came in, I saw him on April 17th, 19th, 24th, 27th, and the 3rd and 18th of May, and we just watched his pachymetry. And you can see we go from starting at about 812 microns to gradually over this time, you know, we've got him on a variety of drops. Eventually he gets down to about 740, 750, which is about where he normally is. And then he levels off at that point, and he stays pretty stable around there. And so for him, you know, he's one where, again, being able to see this entire global map on him and being able to track that change is really nice to see how much that's changing in this patient. So just kind of in summary, you know, like I said, you know, a lot of the ways that I like to utilize the Pentacam outside of just using, you know, that 4-maps refractive, that general map, you know, is tracking these changes in corneal shape, whether it be, you know, with Ortho-K, after surgery, post LASIK, cross-linking, someone's got an ulcer, anything like that. And then tracking that pachymetry, you know, especially on these corneal edema patients, cross-linking again, any refractive surgeries, utilizing it for contact lens fitting, you know, with Ortho-K, scleral lenses, whether it be just getting good baseline data to start off with or using it to do freeform lens designs, which can be a lot of fun. And then looking at, like I said, the entire cornea is a lot of fun, evaluating that, doing all those Scheimpflug images, scrolling through them just like I do on a like a HD 21 line raster for the macula. And then also, like I said, it's become a really fun and quick tool for me to just look at the anterior chamber on a lot of patients and see, you know what, hey, how concerning, how worried am I about this area? And gives me a better idea, similar to what Dr. Yandell said, in terms of looking at it with gonio then afterwards. So, and with that, I think I will turn it back over to Bill, unless you want me to move on to something else.
Great job, Trevor. This was really awesome. It amazes me every time I do these webinars that I always learn so much from you guys, and I really appreciate you all sharing your expertise. So I do have some questions for each of you individually, and then a couple of questions for the group to see if anyone has any experience with some of the things that were brought up. But first, I do want to state to the audience that you may have seen some software, some displays that maybe your Pentacam doesn't have. So there are 4 different models of Pentacams out there. There's the basic, the HR, the AXL, and the AXL Wave. And there are, in different years, different versions of each of those machines. So not every Pentacam has every software package, but many of them can be upgraded with software, and some can even be selectively upgraded with some hardware changes too. So if you saw things today that you think you'd like to have, talk to your local rep. They can let you know if your Pentacam can be upgraded to get some of the features you saw tonight. So Cheryl, I'm going to start with you. I've got a question that I'm sure you probably have a lot of experience with, because I have an Ortho-K practice like you do, and I bet you get patients that come to you that were fit elsewhere, and now you have to unfortunately wash them out, and washing out is never a fun thing to do. Can you just share with you your experience and how you wash people out, and maybe how you use the Pentacam to help you know when patients might be ready for the refit?
Yes, thank you. That's a really good question. And actually, I do get that question a lot, and it does happen occasionally. You know, best case scenario is you can get some baseline topography information from their previous provider, but a lot of times that's not available. And so it's really nice to be able to use that two map comparison in order to watch for when it stabilizes. We do charge a washout fee when someone comes in because it does take time. And with that washout fee, we include any soft lenses that they might need to kind of get them through when they will be finished with their washout. Depending upon how high their prescription was, the age of the patient, how long they were in Ortho-K, and just that patient's individual corneal rigidity, it can really vary. But I think that generally accepted, most patients will wash out somewhere around the 3 to 6 month mark. So when I have that patient in my chair, I take a baseline scan of them doing Ortho-K, right? So that's kind of them totally flattened. And then we will give them, if they have any information on what their previous prescription was, you know, we'll kind of give them a variety of different lens powers, usually about 3 different lens powers, maybe somewhere around like a 1, a 2, a 3, something like that. And we'll just tell them to, you know, kind of monitor and see which ones work best. I also like to send the patients home with a link to an online acuity chart that they can do with an iPad or a laptop at home, so that they can kind of gauge how they're seeing. But you do have to talk to those patients about making sure that they're not over minusing themselves, because they can do that very, very easily and then just cause a lot of headaches, eye strain, things like that. I like to see those patients back usually about a week after they start their washout, to just kind of see what prescription range they're falling into and adjust with new trial soft lenses or daytime lenses that they can wear. And then a lot of times after that, I will see them again about a month later, and then about 6 to 8 weeks again after that visit. So it's not a whole lot of visits, but it's, you know, it's a fair number, so you do want to charge for that. And then after that, around 3 months or so, then I want to see them again a couple weeks later and see if it has stabilized. If it looks like a pretty normal cornea at the 3 month mark, a couple weeks later, check it again, see if it looks the same. And once you get 2 scans on different days that look about the same, you know you've pretty much achieved kind of back to that normal cornea shape. I hope that answers the question.
I think it does. I think the biggest mistakes I've made in that area is not waiting long enough and then trying to design a lens when they're really not ready yet, and that can just cause heartache for everybody around.
Similarly, Bill, I've used it for older patients who've been in RGPs for ages, maybe even a PMMA lens. I had one gal that was in her mid to later 50s that took almost a full year to go to a normal cornea shape from an RGP lens that was really misfit or highly warped and very old.
It amazed me. About 3 months ago, I had a patient come in wearing a PMMA lens. Haven't seen one of them in over a decade, and had to do exactly the same process. And it took it's still not ready. They're still in an RGP, and it's still a nightmare. But the Pentacam is at least telling me what's happening and what's going on, and it helps the patient understand it too. So great answer. Kat, I have a question for you. I know the name of this presentation was pretty much everything but keratoconus, and I know you do a lot of refractive surgery stuff, so I'm going to try to stay away from the keratoconus part. But one of the things that I use the Pentacam for that we didn't talk about tonight at all is ICLs. I mean, do you do ICLs in your practice? And if you do, how do you use the Pentacam to screen patients for that? Oh, you're muted.
I'm muted, sorry.
Okay.
Our surgeon, we haven't had a lot of ICLs come through, but when I have looked at ICLs, I'm definitely looking at the anterior chamber depth and how much space they're going to have in between the iris and lens. I love that the Evo ICL came out, that you can have the hole through it, so you don't have to worry about the
Yep.
doing the LPI, all that kind of stuff, because that makes me more apt to want to offer that to my patient, because that was more my worry. I actually have an ICL patient who he has his pigmentary dispersion glaucoma suspect now because of his Evo ICL rubbing up against his iris. And so we're using the Pentacam to monitor that relationship for him every 6 months. So hopefully he doesn't convert, but it's yeah.
Yeah, I
Here,
see
there,
that anterior chamber depth. Immediately knows if I'm going to even consider an ICL as an option for a patient, so it's really good. The other thing I found neat about it too is you can look at the vault. Obviously, you can see the vault and slit lamp pretty easily, but the Pentacam is a picture of the vault that I can share immediately with my surgeon. If I have a concern about the vault and I want to share it, it's easier for me than taking a photograph in the slit lamp and trying to get that perspective. The Pentacam shows a really nice view of the vault, and you can get it at any angle that you want. A question about refractive surgery, even though again I said we won't do keratoconus, but I noticed that no one tonight mentioned the Bell and Ambrosio enhanced ectasia display, and I know that in most refractive centers that's like the key staple of everything. I'm just curious from all three of you, is that something that you look at and something that you use? And I know in optometric practices it's a little different, but just a comment, Kat, if you want to start on that.
All the time, especially with my Ortho-K patients. So looking at that backside elevation, make sure that we're not masking any keratoconus. And then basically every patient that I have walking through my door, if I think that they have any sort of corneal irregularity, I 100% go to the Bell and Ambrosio. So I am always checking that just to make sure there's nothing that we're missing, for sure.
Awesome. Trevor, for you, a question about scleral lens fitting and Pentacam. I know the CSP is awesome, whether it's the 5-shot or the 1-shot. It's really changed the way I fit scleral lenses. For you, has it changed the way you use trial lenses at all with scleral? I know one of the banes of my existence was the 3rd trial lens I'm putting on that patient, and now they're hitting the 2-hour mark in my practice, and my techs hated it, and I hated it, and patients hated it. Can you just mention a little bit about how it's changed the way you fit lenses and how this whole process of fitting a scleral lens has changed for you?
Yeah, I mean, like I said, it's really become such a, it's a tool that, as long as, my tech is in, which she's in most, pretty much every day that I'm in, unless she's sick or something like that. Now, if I've got a new patient, she just gets that scan on every single one of those patients who's going to be a scleral lens patient. And then she knows, I've already showed her like, all right, send across, the 15/8 and the 13/8, and she does that on every single one of those patients. And then I just know, like, all right, I'm going to go grab this lens and put it on the patient's eye. My ultimate goal, I just, we all get busy doing things. I just haven't taken the time. But my goal is to eventually just train my technician to say, like, all right, here's the depth of lens I need, and she'll just put it on the patient's eye for me, so I don't have to.
I'm doing that right now. It's amazing.
That's my whole goal.
just started the training. Yeah. Game changer.
Yeah, I've been talking about doing that training with her for like 6 months, and she's really pumped about it, and I just keep having other things come up. So, but that's my ultimate goal with it. But yeah, that, and then once you get to like just looking at the edges, the amount of elevation change and toricity in the sclera, it just really helps you fine tune that so much faster. It takes out so much more of the guesswork, which makes it like I said, just makes it much more efficient when fitting these lenses. So, and saves you a lot of headache, your staff a lot of headache, and saves your patients a ton of time. So
the biggest revelation for me is the day after I got my CSP was, I can't believe how much toricity there really is on the sclera. Yeah. And I went from fitting maybe 10% toric haptics to fitting like 70% toric haptics on patients. It just was mind blowing for me. I just didn't know what I didn't know. And all of a sudden, all that midday fogging, all those problems that we kind of settled for, I mean, are almost never happening anymore. So it's really cool. Cheryl, one of the things I know, cataract surgeons always brag about their 7-minute cataract surgery or 8-minute cataract surgery. I know a lot of people like myself with Ortho-K, at least to myself, I always like how many one and dones have I done? Did I get an Ortho-K done in one lens design, and was that it? Can you mention a little bit about what changed when you started using Pentacam and Wave to design your lenses? Did it change anything like that for you, either in your one and done rate or your cost of goods or things like that? Did anything like that change for you?
You know, it sure did. I think that, you know, one of the things that probably impacted me the most was when I started using Wave, I understood the design of the lens so much more. When you're the one looking at all of those parameters and you can adjust all of those parameters, and you start to just get a deeper level of knowledge with how that lens is designed, I think that just leads to being able to create lenses that work, you know, that from that first time. So yes, there are still occasionally patients who surprise me that they don't mold as much as I thought they were going to mold, and so then I end up having to, you know, increase that topographic demand or flatten that base curve a little bit more. But boy, I'll tell you what, it really does nail it on that first fit most of the time. And I do think just having the ability to look at the amount of data that we have, it's just really fantastic at increasing your understanding, which makes you much better. It trumps calling a consultant and just trying to describe to them and then ultimately just sending a topography over. Being able to do it yourself is the way to go.
I totally agree. And I think we've hit our 1 hour mark. So before I thank each one of you, I just want to say that, wow, I just learned so much tonight from you guys, and I can't tell you how much I appreciate you sharing your expertise. The Pentacam is truly like the Swiss Army knife of ophthalmic instruments. It's just amazing. I think we could probably do 3 or 4 more of these and never repeat the things that we did because of all the other things we didn't even touch on, like corneal, like lenticular opacification, all these other things that this machine can do. So again, I want to thank each of you for putting this together. This content was fantastic, and I want to thank everyone tonight for the questions and participating. And this will be available on recording for anyone that needs to rewatch it. And again, thank you guys. Have a great evening.
Appreciate it. Thank you.
Thank you.
Thanks so much.